Okay, we are live. My name is Michelle Morand. This is Alex Rowland, and we are the founders of Cancer Treatment Options and Management. Today, our purpose in being here is to answer some of the questions that you sent in and any questions that you ask as we go about cancer care, cancer prevention, anything you want to know. Alex is here to answer your questions. So I'm going to be monitoring the comments section here as we go. So anytime that you have a question, go right on ahead and ask it, and I will make sure Alex answers it for you. Hello, Alex.
Hello, Michelle.
Let's start with a question from Jane Williams. Let's see here. Jane's asked a question about breast cancer. Two questions, actually. The first question is, how long after you finish your treatments for breast cancer are you considered a survivor?
Well, first off, I would say as soon as you finish your treatments for breast cancer, you are a survivor as a start. There are many different subtypes of breast cancers, a variety of different molecular features for every breast cancer, and all of them have different survival rates, different times of recurrence. So it can vary greatly between different subtypes. There's also the stage to consider. I think most oncologists will look at 5 and 10-year survival rates as milestones. I would say that it's unlikely that you're going to see a recurrence after 20 years.
Oh.
So then you can guarantee you're home safe.
That's a long wait.
Yeah, it can be a very slow progressing disease in certain patients.
Okay. She had one more question here. Let me get to that. So the point is, if you've made it through your treatment, you are officially a cancer survivor.
Yes.
But you have to wait quite some time to know whether it's going to come back or not.
Exactly. Yes.
Okay. I'm curious to know, what are some of the common reasons that cancer might come back?
Well, cancer is a disease of the stem cells. It comes from what's known as adult stem cells. We have 2 different types of stem cells. We have what's called hematopoietic stem cells, and we have adult stem cells. And adult stem cells are the cells that repair our body. You can consider cancer a wound healing process where the stem cells get tricked into repairing wounds that aren't necessarily there.
Oh.
And so there's a constant process of cancers always trying to come back. Standard chemotherapy typically will target the bulk of the tumor, but the stem cells that have produced the actual tumor in the first place are going to be, so they sort of live in a false state of life. So they never really die. They just kind of exist in a metabolic state.
Oh, so it's always kind of there.
Yes.
And then what might trigger it to resurface?
It's a standard process that's just constantly going. There's many factors will decide whether it comes back or not.
So here's where prevention, or making sure you're doing your best with other things after treatment in terms of diet and exercise and good self-care.
Yes.
Yeah, we'll get into that later. You may have some specific questions about that. So one more question from Jane Williams. Can radiation leave you with a cough?
Yes, it can. Yes, definitely. It affects your immune system, and so you can be susceptible to secondary infections. That was not from radiation, as far as I know.
Well, you haven't, yeah, right. As far as we know, we haven't had the radiation. Okay, so we also have a question here from Sharon Curtis. Sharon's, you were asking a question about your husband with lung cancer and metastasis. Metastasis to the lymph nodes. You mentioned he did chemotherapy and he also did immunotherapy, but nothing has worked so far. So we have lung cancer with metastasis to the lymph nodes. Chemotherapy and immunotherapy have been done, and understandably, Sharon's wondering, is there anything more that can be done?
Yes, so there's been a lot of new developments in lung cancer in the last few years, some very interesting new drugs and approaches. As with every cancer, it's all going to be based on the molecular features that are unique to each cancer and each subtype of lung cancer.
Oh.
So there are probably about 8 or 9 different targeted molecular drivers of cancer right now. And these particular drivers all have drugs that will target them. So the key is to finding out which one of those mutations is driving your cancer. And then once you find that out, then you could target it with the particular drug. If you don't have that information, then you're flying blind and it's really hard to come up with a proper treatment protocol.
Okay, so find out what mutations have caused your cancer, exactly. And then you have a lot more options.
Yes.
Okay, so let's go to the question that you're probably wondering, which is how do I find out what mutations are driving my cancer?
Well, most hospitals in Europe and the States do a tumor sequencing panel. A common one is Foundation 1. It looks at about 350 or 360 different genes involved in cancers, and that's probably one of the best ones. In Canada, it's a little more spotty. A lot of hospitals are developing their own, what we call a targeted panel, where they'll look for specific key mutations, but they won't look at the entirety of all of the different mutations. And that brings us to an important subject. When you just look for specific mutations in a gene, you tend to miss a lot of really important information.
So for example, remember Alex is the expert. He works in this 24/7. His head's always immersed in this personalized cancer treatment process and leading edge science. So these things to him are just obvious. But for most of us, we need a little more background on what, like I say, give us an example of a single gene test that might be done for somebody and that you're saying you'd want more.
Okay, so every gene is based on a sequence of DNA base pairs, and these DNA base pairs form amino acids or encode for amino acids, and those amino acids form a chain which then becomes the product of the gene. So genes can vary in length of how many base pairs they have. You know, they can be fairly short with 50,000 or so base pairs. Some genes have hundreds of thousands of base pairs. So to give you an example of how many different mutations you can have in a single gene, once you have 150 base pairs of DNA, the possible combinations of mutations in that 150 base pairs is larger than all of the atoms in the known universe.
All right, so back up the bus. Say that again. What?
That is a staggering number with many zeros attached to it.
Holy cow. And how is that relevant to us as we're talking about genetic testing for cancer treatments?
Well, it just goes to show that there can be an infinite amount of different mutations in every gene.
Right. And
so when you take a targeted panel that only looks at 1 or 2 mutations in a gene, you miss all of the information, literally.
So something, for example, if I'm getting a test to see if I have, what would be one? BRCA1.
Yes, that's a great example.
Okay. Why is it a great example?
Well, a lot of the common tests being used these days, there's many databases of BRCA mutations. And a lot of these databases focus on mutations that have been discovered and that have some research on them. So when you get a sequencing panel that has a BRCA1 mutation, what they do is they have a computer program, a software, that will say, yes, we recognize this mutation as being cancer-causing or not. But the BRCA1 and 2 genes are tumor suppressor genes. And so they have to be functional in order to work and prevent cancers. A tumor suppressor, as you probably know, prevents cancers from developing further. So the problem is with most BRCA1 and 2 testing, and we see this quite a lot, even in tests like Foundation 1, if it's a mutation that they haven't recognized before or hasn't been discovered before, and there's a huge chance that that's going to happen.
Given how many there are.
Exactly. Then they tend to ignore it and call it a variable of unknown significance. Now, the type of mutation is very important. One of the types of mutations that we get, that we see a lot of, is called a stop codon mutation. And that causes the gene to stop producing its transcript right in the middle of where that stop codon is inserted. So that mutation causes a stop codon. If that happens, the gene is non-functional and it doesn't do its function. It doesn't protect you against cancer. So we have seen, we've seen tumor DNA sequencing tests where the patient was told that they didn't have a BRCA1 or 2 mutation, and that the mutation that they had was not significant when it was actually a stop codon mutation that had just never been reported in that position before.
And what was the consequence of that?
The consequence is the person had a BRCA1 mutation in their family, and their children had it, and it was passed on. And more importantly, when you have breast cancer or ovarian cancer with a BRCA1 or 2 mutation, there's some targeted therapies that will work really well for you. PARP inhibitors is one example. It can also dictate certain chemotherapy protocols, such as platinum-based therapies.
And those are obviously better than standard chemotherapy, or more.
It's going to tell you what's going to work and what's not going to work.
I see.
And that's very important.
Right. Yeah. So you're not wasting your time or getting the wrong treatment.
Exactly.
Yeah. I see. Okay. So let me see what else have we got here. Oh, well, that actually comes right to our next question here from Mary Ellen. My mother-in-law died of breast cancer. Is my daughter at risk? And if so, how much and what should I do?
Well, that's a great question. Depending on what age her mother died of breast cancer.
Okay.
So typically we have what's called the Amsterdam criteria. And what that refers to is if somebody has a cancer before the age of 50, it's likely an inherited germline mutation. It's certain. Depending on what age.
Sorry, folks. Hang on a second here. What have I done? Hang on a second here. Hang on. Somehow we've got Alex playing here on the screen, and we don't want that. No disrespect to you, Alex, but we want to be able to hear you live. There we go. Okay, go ahead. I've got that turned off now.
So to backtrack, the Amsterdam criteria, if you have a cancer before the age of 50, there's a very good chance that it's based on an inherited genetic mutation. Okay,
so before 50. Okay. Yes. Okay, so I guess, Mary Ellen, the first thing is, how old was your mother? And let's say it was before 50.
Then I would say definitely get genetic testing, get inherited genetic testing.
Okay.
But I mean, it's very important to get genetic testing regardless of what your cancer is.
Right.
There's various forms of inheritance. One of the new things, the new paradigm shifts in cancer inheritance, it was thought that cancer-causing genes are only inherited through what's called the germline. In other words, every cell in your body has that mutation, and therefore your children are going to have it or have a good chance of having it. And that's called a germline mutation. But what we see mostly in cancers is what we call, and I've kind of coined this term myself, is a inherited somatic mutation. And that is a process that's very much similar to diseases such as Down syndrome, where the sperm or the egg is actually damaged in some manner, and the recipient of that sperm or egg happens to have a mutated cancer gene. It's not necessarily passed on to their kids. It's not necessarily found in their brothers and sisters who were formed from different eggs and different sperms. It's a one-shot, and it's very much like Down syndrome, where healthy parents can have a Down syndrome child, and where a Down syndrome child can actually have healthy kids. So it's not passed on, it's a one-shot deal. And I like to refer to that as inherited somatic. So that is much more common in cancer. We see that in most cases where the mutation is detected at a very early age, but it's not found in other family members. So it's not a germline mutation, but it is causative.
Okay. Now I'm interested to understand a bit more about genetic testing, and because you talk about how, even a very well-regarded test like Foundation Medicine, which is a nice big panel, has been around for a long time, and something that you use often. But you're talking about how the way that they report their information, or certain things that they report, can be confusing or missing certain piece of information. So there's so many different genetic tests out there. How does somebody know if their doctor's recommending, for example, a single gene test, or a panel that looks at 10 or 15 genes? And again, Foundation Medicine looks at over 350, just so you know kind of what's possible out there. But how would somebody know whether what's being recommended to them is actually a test that works well, or will provide them with the information that they're looking for? Because there's lots of genetic tests that don't really go very deep and look at much, I know.
Well, I think that's an excellent question.
Thank you.
I think the important thing to consider, once again, to back up the bus, is that there are a ton of different possible mutations that can occur in cancers and that can cause cancers. So
the more you're looking at, the better.
The more information you're looking at. The second thing that is really important to consider is that for the last 20 or so years, since we've identified DNA and transcribed the human genome, I think what's really important to understand is that there's just a ton of information coming our way. Every time a new mutation is discovered that causes a cancer, right away all the drug companies start designing drugs to target that particular mutation. Now, that mutation may only occur in a certain percentage of the population with that type of cancer, but for that population, that mutation, that drug could be a cure. So to give you an example of the scale of this information, there's roughly 225 to 250 different cancer conferences internationally every year of varying sizes. One of the largest that happens every year, ASCO, it can have up to 7,000 or 8,000 different presentations or abstracts. So the number is overwhelming.
So wait, one conference out of 200 plus each year has 7,000 to 8,000 different papers or studies being presented.
Yeah, and maybe one of those is on a genetic mutation that is unique to you. And it shows how a certain combination of drugs work incredibly well or don't work. And you would never have access to that information if you didn't have someone curating your sequencing data.
Right.
So the key, most of the sequencing tests are very good. They all use the same protocols. They typically use the same sort of, third generation, second generation sequencing. It's called next generation. And most of them are going to identify those mutations very well. Whether they report them, how they report those mutations, and what you do with that information is really key to cancer.
Okay, so apparently many genetic tests are of good quality. You don't have to worry about that.
Yes.
It's how the results get interpreted and utilized.
And applied.
Right.
Yes.
Yeah. That's interesting. Okay. Laura. Hi, Laura. Laura has a question. Laura Waters is interested in why cancer can skip generations and how.
That's a great question, Laura. There's a variety of reasons, and it depends on the cancer. A lot of cancers are based on lifestyle, and it's hard to predict which cancers are based on lifestyle and which aren't, and if there's a genetic factor. If you have susceptibility, if you have gene mutations that cause a susceptibility, they can create a sensitivity to certain chemicals, environmental chemicals, dietary, exercise, many different factors. We see patients that have a sensitivity to radiation. And if those patients have that information, then they can be told to stay out of the sun. Maybe they have a sensitivity to dietary acrylamide, and they can stay away from processed foods. So you can have the genetic sensitivity, but if you have a very healthy lifestyle, it can override that sensitivity. Right.
So here we get back to prevention. So how would somebody know? Would they have some genetic testing that would tell them they have these kind of tendencies or these sensitivities? Or
I
how would you even
think
know?
genetic testing is very important for everyone.
So what kind of a genetic test would you use for something like that?
I would use an inherited genetic
An
panel.
inherited.
Yeah, you know, a simple 150 gene inherited panel. Look for the most obvious genetic drivers, and if there's nothing there, then you can start looking at lifestyle factors. You know,
So when you say simple,
smoking is a big one.
You know,
alcoholism, smoking, drug use, and poor diet. Sedentary lifestyle is worse than smoking.
Wow.
You know, lack of exercise can be just as damaging as smoking.
That's something, because we all know how dangerous smoking is. I mean, you've seen the cigarette packs, whether you're a smoker or not. So you're saying that a lack of exercise has been proven to be more cancer causing than that.
Yeah, and the reason for that is there's a variety of mechanisms. It's what we call metabolic inhibition. So muscles use up a lot of processes and a lot of growth factors that cancers would normally use. So when you're not exercising your muscles, these growth factors are available to tumors that may or may not develop into, you know, large-scale cancers. So we all have cancer cells floating around in our body on a daily basis. Our bodies typically take care of those. Our immune system attacks them. But if we're sedentary, then they have access to more growth factors that the muscles would normally be using. So it's a competitive metabolic process. Additionally, we have something called a lymphatic system. The lymphatic system is like a blood vessel system, and it goes all over our body. It transports immune cells and fats and dead cells and everything through our body. The problem with lymphatic system is it is like maple syrup. It moves very slowly. So the only thing to increase the flow of lymphatic fluid is to exercise rigorously. And when you exercise rigorously, it increases the flow, and then it allows all of the products and, you know, potentially cancer cells that are hiding out in this lymphatic system. It provides exposure of the immune system to them through the lymph nodes.
Oh, so it's kind of a double whammy. Double
whammy, yeah. So there's also another process called angiogenesis, which is the cancer or tumor-based recruitment of blood vessels. When you exercise, you destroy your muscle tissue, and your muscle tissue gets rebuilt, and it gets a new blood supply. And so your muscles actually recruit blood vessels to it in a process called neogenesis. And so angiogenesis is a process where cancer cells actually recruit those same blood vessels to them. But cancer cells, the angiogenesis process is one step shy of neogenesis. And so it results in these blood vessels that are kind of leaky. And because of that, the tumor cells are able to leave those blood vessels and spread throughout the solid tissue. So when you exercise, you create the process of neogenesis, which causes your muscles to, you know, recruit that blood supply, and it prevents, it takes over and uses all of the proteins and the processes that the cancer cells would normally do using angiogenesis.
So if you have cancer, exercising is
very important.
Hugely important. Probably one of the last things you might feel like doing.
Exactly.
But for all those reasons, it really slows the ability of cancer to develop.
Yes.
And did you say already, I was a bit distracted here, what kinds of exercise would be best?
What's best is rigorous exercise, like weightlifting, good cardio, you know, hiking up a mountain. Short bursts of high intensity exercise is really what's best. And there's another process involved. When a muscle tissue exercises, it releases these things called cytokines that actually prevent the growth of cancer cells in a petri dish. And there's actually drugs being developed right now that mimic these, and they've isolated these actual chemicals and are using them in drug development to try to copy the process. So there's a multitude of ways, and you know, the data is very clear. You know, for example, the recent study from the Mayo Clinic showed that when women with breast cancer exercised, weightlifted, it almost doubled their survival time. Very significant information.
How much weightlifting?
You know, you don't need a lot. You know, 3 or 4 times a week of maybe 20 to 30 minutes, as long as it's intense. It's the intensity that's important.
Okay. So there's a study from the Mayo
There's
Clinic.
many studies.
Okay.
Many studies. This is
All
just
right.
a recent study.
But that's a huge statistic.
It is. Yes.
That just that one piece,
Yes.
you know, 20 minutes 3 or 4 times a
Yes.
week.
This is for stage 4 breast cancer patients.
Wow. That's amazing, really, when the cancer is that advanced and something like exercise
Yes.
that is within your own control and not a pharmaceutical
No, exactly.
makes such a big difference.
Yes. Lifestyle's everything.
Wow. That's really quite remarkable. All right, another question here for you. Okay, some questions about cancer treatments. Is cannabis a good treatment for cancer?
It depends on what you want to do with the cannabis. Cannabis has many great properties. I would say that it has a role, a significant role in CBD specifically in reducing inflammation, and it prevents seizures. So when patients with brain tumors, have seizures, that can be a very life-threatening situation.
Yeah, I think so.
Cannabis can slow that down. Now we're talking extracts. We're not talking smoking. Smoking of any form is not a good thing. It creates many carcinogens, and it's just a bad process.
So when you say extracts, you mean like CBD oil?
CBD oils.
Because I hear a lot about that.
Yes, yeah. It has a variety of different roles with nausea and inducing appetite and helping people be calm and sleep. As far as actual studies, I think there's about 150 different human clinical trials using cannabis right now internationally. There was a lot of studies done in Israel, but most of it focused on the side effects and reducing the side effects. Pretty well all of the studies that have used it to try to fight cancers have failed. It's no better than broccoli. Which is still very good. Vegetables are very important, but it's just not going to have that kind of impact. And that's because the genetics of every cancer is unique to that person.
Right. So it would depend on the mutations that are causing that person's cancer as to whether the CBD oil, for example, was going to be working
There may
properly
be
on this.
a person that has the perfect combination of mutations where CBD would be effective. It's not going to be curative.
Right.
But it's going to, it could slow the process down.
And you would identify that with genetic testing as well.
Yes, exactly.
Yeah. All right. Interesting. So there's a question about chemotherapy. It's a pretty general question, which is good because we want to be looking at this from a broad perspective. So the question is, what are some alternatives to chemotherapy that work?
Well, chemotherapy is it's on its way out. What most people don't know about chemotherapy is based on plant phytochemicals, typically. They're called plant alkaloids, and they're the way plants fight against predators. And so they're usually harsh or strong tasting chemical compounds. And most of them are isolated from plants or fungi and molds and so on. And what they do is they prevent cells from copying themselves. So they interfere with the DNA copying process. And they typically do that in a cell cycle called M metaphase. And basically what they do is they will prevent every rapidly reproducing cell in the body from copying itself while the drug is in your body. Now that may be good for a rapidly reproducing cancer, but if the cancer isn't growing at that particular moment that you have that drug, then it's not going to be effective.
Okay, backing up. So how chemotherapy works is it stops all the rapidly reproducing cells from reproducing, which it means, again, hair,
skin, nails.
Right. So that's why we have these strong side effects with chemotherapy.
A lot of our organs are lined with skin. And that skin is rapidly turning over, rapidly reproducing. And what can happen is the chemotherapy will interfere with that, and then you can have stomach issues and nausea and so on. So there's a lot of side effects that happen from this process.
Okay.
The other thing is chemotherapy does not target the stem cells that produce all cancers. And we know that because when you have standard chemotherapy, your hair falls out and your nails are damaged. But as soon as you go off it, your hair starts growing back. And so that just shows you that the chemotherapy did not affect the stem cells in your hair roots, and therefore it's not going to affect the stem cells.
Right.
Of
If
the
it's
actual
working
cancers.
on all of them equally, and those ones are still there and growing, then almost certainly your cancer cells are as well.
Exactly.
Yeah. Wow.
So we haven't really developed any new chemotherapy drugs in a long time. Most of the chemotherapy drugs we're using today in Canada were developed in the 70s and the 80s, and some in the 90s, but we haven't really developed a lot of them now. All drug development these days is either immunotherapies, which target the cancer's process of shutting down the immune system and reverse that, or are targeted therapies, which target a specific genetic mutation. In other words, they will only affect the cells in your body that have that cancer-causing mutation. And that is the vast majority of treatments these days.
Right, so they're just, understandably, because of the problem you mentioned, they're not designing new chemotherapies.
Exactly.
But this begs the question, at least to me, why are we still using chemotherapy so much?
Well, chemotherapy can be very
issue?
effective on decreasing the bulk of the disease. So if you have a lot of tumors in your body growing all over the place, they're going to cause problem and damage to the organs. They're going to be pressing against nerves. So when you get a massive dose of chemotherapy, you know, most of those tumors are going to shrink down. Of course, they're going to grow back, and of course, they're going to come back. But it gives you some really good temporary relief, and it allows your body to heal a little bit from the damage of these tumors. Yeah. So we like to use chemotherapy as a last resort. And the reason we like to use chemotherapy as a last resort is because it does target any sort of cell regardless of the genetic mutations. If we can catch a person's cancer early on when they're first diagnosed, and we do our genetic testing and we identify the drivers of that cancer, then we can actually control that cancer for many, many, many years using targeted therapies and liquid biopsies. You know, we just follow the mutations. As new mutations occur, we detect them with liquid biopsies, and then we bring in a different drug. And so we're turning cancer into a chronic disease rather than a terminal instant disease.
So manageable condition.
Exactly.
Right.
Just constantly using different drugs. And because these targeted therapies only target the cells with that particular mutation, they don't affect all of the body cells. And most people can have very normal lives while on these targeted therapies. And you know, they can go back to work, they can do their bucket lists, they can do all sorts of things.
And have many more years of life.
And then when it finally reaches, you know, when we run out of targets, which, you know, is happening less and less because literally every day there's a new drug out. You know, with all those different studies, there's a new mutation being discovered and a new target for it. And, you know, all of the drug companies are trying to outdo themselves for each target.
Sure.
So once we run out of targeted therapies, then we say, okay, now let's hit everything with the chemotherapy. And that will get you a couple more years of survival.
Okay. So you said something you kind of rapidly in there about a process that you take your clients through to help them to have these extra years of good quality life. And it starts, as you mentioned, with genetic testing.
Genetic testing, yes.
You said something about curation of data, like these thousands and thousands of tests and everything that are coming out that your oncologist does not have time to read or to, you know, deep dive into and understand for your own case. You said targeted therapies. Tell us again how targeted therapies work.
Targeted therapies will target any cell in the body that has that genetic mutation.
Okay, so we do the testing and we find out what mutations you have. Correct. Then we do some research. What's the point of this research?
To find out what the best drugs are in real time.
Okay, now, what's available?
Yes, so I can give you a perfect example with a case study if you'd like.
Okay.
So we had this lady, Sherry, she's on our website, her case information. She was a young 50s woman who had lung cancer. So she was diagnosed with stage 3 lung cancer, and her oncologist did a spot test for her lung cancer. He said, you know, you've never been a smoker. You must have some sort of genetic mutation. I'm going to test you for this gene that I've heard of that we have some drugs for called EGFR, epidermal growth factor receptor. So he tested her and he found out that she had this mutation called the L858R mutation. And he put her on a drug that targets that mutation. He put her on a first-generation drug. So in other words, when the mutation first gets discovered, they create a drug. That's a first-generation drug. Then another company comes along and says, hey, we've got a better drug than that drug. It works better, it's got less side effects, and it kills more cancer cells, and patients live longer. That's the second-generation drug. Then another pharmaceutical company comes along and says, oh, we've got an even better one than your drug. So, you know, this drug is now third generation, fourth generation. So she was put on a first-generation drug. And that drug typically gets you about an increase in about 2 or 3 years survival without needing chemotherapy. So she was literally able to have, you know, 2 years, a chance of 2 years survival on this drug with no side effects or minimal side effects. And, you know, hopefully that would be beneficial. So immediately after being on this drug, all of her tumors shrunk. All of her tumors went away, or, you know, shrunk right down. Her doctor was very happy with it. She was very happy with it, and she went back to work. She was a teacher, and she went back to work and started enjoying her life. And then her cough started coming back, so she called us. So the first thing we did was we looked at her information. We saw that the doctor had also done something called a PD-1 test that determines whether she would get immunotherapy or not. Now, we're not sure why he didn't give her the immunotherapy. I assume he was saving it for a later date, but she was highly positive for this marker, and she would have responded to this immunotherapy. It's considered, you know, a last-ditch resort when really it should be the first-line therapy. And that's just because the Canadian medical system can't really afford to pay for these drugs. They're very expensive. So anyways, her doctor put her on this first-generation drug. Now, as it so turned out, she had some other mutations that limited the benefits of this drug. But those other mutations have been the subject of second and third generation versions of this drug. So we knew right away that if her cancer was coming back while on this drug, that she should have been given a third generation drug. And the third generation drug was actually approved. It's called Tagrisso, and it was actually approved 2 months before she was diagnosed. It was approved in Canada, and the Canadian medical system was covering it.
So it was available all that time.
It was available. The doctor just didn't know about it. You know, and he's got his hands full.
That's so common. Yeah.
So this drug would have worked for her perfectly, and she would have got many years of cancer-free benefits. Unfortunately, the Canadian government only approved it as a first-line treatment. In other words, it had to be the first drug you get, or you don't get it. So by the time she found out about this drug, when we informed her about this drug, she had already been on this other first-generation drug, and the doctor wasn't able to give her this drug that would have saved her life.
Well, no. So could she have got access to that drug another way?
She would have had to pay for it out of pocket. We also spoke with the drug company for her, and the drug company had agreed to cover the costs partially for her. So what we did, what happens in EGFR mutated cancer is when these drugs stop working, there is a new mutation called the EGFR T790M mutation. And there's also another mutation called a MET mutation that can also cause these drugs to stop working. Tagrisso targets the mutation that she has, and it also targets this emerging T790M mutation. And there are drugs for MET mutations, yeah, definitely drugs for MET mutations available in Canada. So what we did was the problem is because it's an emerging mutation, it wasn't found in her original tumor. In other words, it occurred during her treatment as a cancer response to the treatment. In other words, the cancer said, hey, you're targeting us with this drug. We're going to create a new mutation that's going to get around that.
And how often is that the case?
That's very common.
Very common.
It's why most targeted therapies fail eventually. Is a new emerging mutation takes over.
So you have to be constantly getting genetic testing, or how do you know?
So the best way to detect emerging mutations is through liquid biopsies. Because the tumor cells shed their DNA into the blood. So if you go back to the original biopsy, it may not have that emerging mutation because the emerging mutation happened after that sample was taken out. And you can't keep going in there and removing tumors, and maybe that emerging mutation was only in a certain part of the lung, maybe it was only in a lymph node. By checking the blood using a liquid biopsy, you always find that mutation. So we tested her, And we found, and this liquid biopsy we did, at the time, her doctor said that she was still cancer-free.
Mm.
He had done a CT scan. And
So she has a cough.
She has a cough. And the CT scan said that her cancer was negative. So what we did was we did this liquid biopsy, and we saw, number one, she did not have this EGFR T790 emergent mutation. So it would have not been a problem for her to get this degree, so it would have still been beneficial for her. But it showed that she more than likely had this MET mutation.
Oh.
So she could have been given a MET inhibitor. So we went back to the doctor and we said, this woman is not in remission anymore. We found her original mutation at a very high rate in her blood. And he said, I don't see how. She has a CT scan. I said, well, here's the data. Obviously her tumors are very active right now. So then we sent her for a private PET CT, and the PET CT discovered that, yes, she was not cancer-free anymore,
Wow.
and that the drug had stopped working. Had she been on the original drug, the Tagrisso that we recommended that was just approved, she probably would have had about 3 years of remission, where in this case she only had about 8 months.
Oh, wow.
Yeah, so
that's a huge difference.
Yeah, so unfortunately, she developed, she was against vaccines, and she hadn't had her pneumonia vaccine, which is available for all Canadians. Every Canadian should get the Prevnar 13 and 23. It's a vaccine that prevents encephalitis and all of these treatment, like these drug-resistant forms of pneumonia that people are dying from in the hospital. And I know about 10 people that have died from this. There's no treatment for these pneumonias. Wow. They're antibiotic resistant, and so this vaccine treats against that.
Tell us again what the vaccine is called.
It's called Prevnar 13 and Prevnar 23. It's free. You get it at your pharmacy, and anyone can get it, literally. You just go to a pharmacy and get it.
And it protects you against these diseases.
23 strains. Prevnar 23 is against 23 strains, including encephalitis and some other horrible diseases. And the 13 protects you against 13 different strains. So that pretty well covers the gauntlet.
Right.
So unfortunately, she didn't get this vaccine, and she developed a treatment-resistant form of pneumonia and ended up dying from that before we could get her on a MET inhibitor.
So initially the diagnosis was off. The CT scan didn't pick up the cancer return, and lots of time was lost. And because of how the system is set up, she was not eligible for the treatment, although you were able to arrange.
And her doctor was really good. He, once he realized his error, he worked very hard to help her get that. He helped her get access. He said, yes, we can get you this MET drug as soon as you're over your pneumonia. So he worked, he worked with her and with us to really help get the best for her. He just wasn't provided with all the tools. He wasn't provided with the information that Tagrisso was indeed free. Yeah.
And again, even kind of the initial test and diagnosis.
Exactly.
Yeah.
Exactly.
Which is so often the case, is that, oncologists, their whole job is about doing their best to make sure their cancer patients get the best treatment and survive as long as they possibly can with minimal side effects.
And minimal tools.
Sure, well, that's it. The system,
minimal tools.
It depends on the system in which these doctors are working, what they're able to even recommend to you. And then depending on the system in which they work, they may have quite a large patient load, which prevents them from keeping up on the research. Again, no one person could keep up on all that research that Alex was talking about earlier, which is why
we try.
Well, we have a team.
We have a team.
Yes, and that's the thing, right?
We go through about 60 medical journals every month.
Yeah,
and
there's a lot of reading.
A lot of reading.
A lot of keeping up with
yes.
things. Yeah, absolutely. So you mentioned two things that I think would be good to do a deep dive into with the time we have remaining. You talked about liquid biopsies a few times, and you talked about PET CT. So let's start with the latter, because there was a CT scan done for Sherry, which turned up nothing. And hence, understandably, with the tool that he had available to him, the oncologist was confident that cancer hadn't returned. He wasn't misinforming her. He was unfortunately lacking the information. But a PET CT showed it. So how is a PET CT different from a CT?
That's a great question.
Thanks.
So most imaging techniques, MRIs, X-rays, even ultrasound, what they do, and I'll use a CT as an example. MRI is a little bit different than a CT scan. So a CT scan they'll take a radiation beam and they'll blast it right through your body. And then they have a detector on the opposite side of your body that picks up the radiation. And so as the radiation travels through your body, different tissues have different densities. And so they will pick it up in a known manner. So, if you have a, lung tissue here and you have a big hole and, your lungs are kind of empty spaces, then the radiation will pass faster through that lung tissue. And then it gets picked up. So the amount of radiation that gets picked up gets put into versus the radiation that was sent, gets picked up and put into a computer software program, and it analyzes it, and it looks for variations in tissue density. And so the theory is that a tumor is going to be either less dense or more dense than the surrounding tissue. So if you have a lung tissue that is all the same density, and then you have this tumor in it, the tumor is either going to be harder and smaller and more dense, or it's going to be more spread out. It's going to have a different density.
It'll look different.
And so then the computer creates an image of that. Unfortunately, it does not tell you whether that is a benign lump, and it does not identify tumors that have the same density as the surrounding tissue. So if you have a tumor that is spreading slowly or is in an early stage, it's not going to get picked up by the CT scan. It's going to get missed.
So CT, it could be scar tissue, it could be a benign lump,
yeah, exactly.
or benign growth, or it could be just small, or the tissue isn't different enough from the surrounding tissue. And those would be three reasons why it would be missed.
Yes.
And commonly, we do see that.
We see a lot.
Things are missed on CT
Quite
scan.
a bit, yes.
The other thing that I think is significant about CT scan, as I understand it, is because of what you just said, please correct me, that's what we're here for, a CT scan, it takes an image, we see this mass, but it doesn't tell you whether it's cancerous or not. And so what oncologists have to do, for the most part, or radiologists, is they have to then wait a while and take another picture.
Yes.
Typically, that's anywhere from 3 to 6 months later that they're taking another image. And then what they're doing to try to see, is it growing or is it scar tissue? Or is it just kind of looking weird but supposed to be there?
Has it changed?
Yeah, is they're comparing these two images to see, yes, what kind of growth has there been. It still doesn't tell them whether it's benign or malignant, but
they assume if it's grown, it's malignant.
Okay.
But by then, it's also spread throughout your body.
Right. We've got, months wasted. So PET CT, on the other hand.
PET CT, it uses a sugar. It's called an FDG. It's a radioactive isotope. They inject it into you. And then what happens is cancer cells, it's attached to a sugar. This FDG is a sugar radioactive isotope. It only lasts in your body for a few hours. And so they inject it into you. You wait a while, and then the tumors, because they're growing so fast, they preferentially drink up a lot of this FDG fluid, much more than surrounding tissues. And then what they do is they give you a CT scan. And so anywhere that has a higher concentration of this FDG is going to glow like a Christmas tree. So even if a tissue is the same density, it's going to be a cancerous tumor is same density. It's going to be drinking up more of this FDG fluid, and so it's going to glow
It's going to stand out.
It's going to stand out, and quite significantly.
Right.
Now, important thing about a PET CT is the amount of the sugar radioactive isotope that this tumor drinks up is referred to as the serum uptake value. And you'll see it on a PET CT report. You'll see SUV was 4.1 or SUV was 18.9. And that tells you how aggressive that tumor is. So you may have a very small tumor that is, just on the edge of your arm that has an SUV of, 30. That tumor is going to metastasize and it's going to grow fast, but it's easily removed. You could just cut it out. And then you may have this massive tumor in your abdomen that only has an SUV of 4. and that tumor is almost dead. It's not very active, but most of the focus is going to be on that tumor. If you're being treated just based on a CT scan, they would totally miss the highly aggressive tumor over here, and they would focus on this tumor that's almost dead. That's almost dead, and totally misguide it.
Right.
And so BC Cancer did that interesting statistic that was reported in the Vancouver Sun a few years ago. I think it was like, they said when a PET CT is done, 87% of the time it changes the treatment plan. I don't know how accurate that is, but that was just what
that's
they
their own
reported
statistic. Yes.
And that, I mean, that was why they were building their PET CT machine.
Right. So PET CT is still not used as a standard diagnostic tool for cancer in Canada. There's maybe 30 PET CT machines in the country in public health care.
I'm not sure. I think it's about 35 now.
That's 35. Yeah. In the United States, there's thousands of PET CT machines.
Yeah, about 4,000 or so now.
Yes. And it is often used as a diagnostic tool for cancer as a first line or second line.
One other thing I wanted to mention about PET CT is when it is used to monitor a cancer, we have criteria that determines whether a person is responding to a drug. It's called the RECIST criteria, and it refers to 4 different response types. So you can have what's called a complete response, which is over 30% reduction in the tumors. You can have a partial response, which is less than 30. You can have a stable disease, which is no change in the tumor, no growth, no reduction, which is also a positive thing. The tumors are not growing. And then you can have progressive disease, and that's where the tumors are continuing growing. One of the things that you're going to see the most is what's called a mixed response. And that's where some of the tumors shrink and some of the tumors don't. This is
in the same person?
In the same person.
With the same treatment?
Yes. And that's because, the slightly different genetics and slightly different features. Some drugs will enter, for example, some drugs will be more effective in certain tissues than other tissues. They'll have a problem accessing other tissues. So not all drugs affect all of the tissues at the same rate or are able to have enough bioavailability in every tissue. And there could be individual genetic differences to each tumor. The good thing about a PET CT is by measuring the SUV, you can see if the SUV is going up or down. So the tumor size may stay the same, but all of a sudden the SUV has gone from 18, for the one over here, down to 3 or 4. Right. And that tells you that even though it's a big lump still, it's mostly dead tissue.
Right. Whereas with the CT, you just see the same size.
You just see the same size, and a doctor would stop treatment.
Because they'd assume it's not working.
Exactly.
Right. Whereas with the PET CT, you can actually see, oh, it is working. This cancer is almost gone. Don't stop the treatment.
Measure the SUV of the individual tumors.
Interesting.
Very important.
Interesting. The other thing that it may be obvious to you is with a PET CT, remember I was saying about CT scans and how it can take 3 to 6 months for the doctor to even know, without supreme confidence, that it is cancer. With a PET CT, how long does it take?
You get your results literally right away.
There you go. So
you don't have to wait months and months and months to see if the tumor is growing.
Now, there are a couple types of cancer where PET CT is not so effective.
Right.
And what are those?
So prostate cancer, the FDG has a problem entering the capsule of early prostate cancer. Now, once prostate cancers are more advanced and spread throughout the body, then of course the tumors drink up this fluid. But they have a bunch of different isotopes now, and they have one specific for prostate cancer, and it works quite well.
Oh wow! So
the technology has changed a lot.
Okay, and is there not something also about the brain and PET CT?
So the brain isn't it's not used as commonly as it should be.
Oh.
MRIs are very effective for determining brain tumors, but you can have something called pseudoprogression, and that is where you get your treatment for the brain tumor, but you're not sure if it's worked or not because the tumor looks the same size or something. So or what can happen more commonly in immune therapies and so on is the treatment's working very well, and the immune system enters the tumor and blows it up and makes it look bigger. So it's actually being attacked by the immune system, and it's actually, half dead or dead, but it looks bigger on a CT scan because there's all these immune cells inside of it.
Right.
So that's called pseudoprogression. And so that can happen a lot in brain tumors. And a PET CT is very useful for determining whether you have pseudoprogression or actual progression.
In the same way as you were just saying earlier about you can tell whether it's just tissue.
Yes.
Or live cancer.
Bottom line, go with the biological activity and not the size.
There you have it. There's a good
Always.
summary right there. Yeah.
Size is not a good indicator of progression.
So in terms of diagnostics for cancer, people definitely want to explore genetic testing.
Most definitely.
But ideally, they will have someone.
And if you're just, if you're concerned that you may have, some sort of disease, if you're just scared of cancer and you want to sleep well at night, get a inherited genetic panel. When I was in medical school, the theory was, we had this big round table, and it was, should we do inherited genetic testing? Because there's been cases where people have found out they have an inherited, genetic mutation and gone out and committed suicide.
That sounds like an extreme case.
And that was the philosophy back then. That's why they thought, maybe we shouldn't be doing inherited genetic testing. And a lot of doctors were arguing about doing this, saying it causes more damage and there's nothing you can do about it anyways.
Well, that's the thing. There was a time when that was true.
Right.
Or at least we didn't know enough
Right.
to be able to know how much, diet and exercise and things would be beneficial.
So now we know, if you have a BRCA1 mutation, that's not a death sentence. There's a lot of things you can do. You can have your ovaries taken out. You can do a lot of different things. You can change your lifestyle. You can avoid smoking. You can avoid hard drugs and alcohol. You can exercise more. You can, switch to a vegetarian-based diet and make a huge difference on whether you get that cancer or not. But more importantly, our new liquid biopsy, our exosome-based liquid biopsy, if you have an inherited genetic mutation, what we can now do with our test, with our liquid biopsy, is we can design a test just for that person. And what we can do is we can test the level of that mutation. So it's going to increase if precancerous processes are going on. And so we can test that person throughout their lifetime and say, hey, we've seen an increase in your mutation. There's no tumors in your body yet, but we know that there's a metastatic process going on. If you did a short course of chemotherapy right now, it would eradicate it instantly. So, chemotherapy in a precancerous condition is very effective.
Very powerful.
Very powerful tool.
So there is reason to find out if you have inherited mutations now, because there's so much you can do for prevention, but also you can use the exosome-based liquid biopsy to see if cancer has started to grow and catch it really early.
We just had a case of this last week.
Right.
We had a young man with a inherited genetic mutation. And we looked at it and, we thought, hey, this is probably an inherited mutation. So we said we should probably test your children. So we tested his children, and luckily, the company that we use will test. If you have an inherited genetic mutation found in your tumor, they'll test your kids for free. And so we jumped on that. We had all of the 3 kids tested. All 3 kids had these mutations. So what we did is we designed a liquid biopsy probe just for that family. It's a rare, unique mutation. It's only in that family. And it is in other families, but it's not a common mutation, so there was no common test for it. So we were able to design a test within 2 weeks for that mutation. We've tested that test. It works wonderfully, and now we can monitor those kids for the rest of their lives with a simple test, simple draw of blood every few years.
Yeah, so a couple of vials of blood every year or 2, and those kids will be right on top of it.
Exactly.
Yeah, that's really
Very
exciting.
important.
Yeah.
Information is such a powerful tool.
Yeah, I'll say. Yeah. Wow. Okay, so there's clearly so much that can be done if you catch cancer early, even if you get an inherited genetic test and you find out that you have some of those potentially cancer-causing mutations. There's a lot that you can do with your lifestyle, significant amount you can do with your lifestyle to slow the development of cancer or prevent it from happening.
Yeah.
There's a liquid biopsy test that you can do just as an annual, like you go to your doctor for a physical every year, you just have your blood draw and have one of those tests and just see, is anything happening? Catching it really early makes such a huge difference to how deadly your cancer will be.
No, the reason for that is often when tumors grow, they die. They can't feed themselves quick enough, and so the interior core of the tumor may have some stem cells in it, but the surrounding tissue will become really tough and fibrotic, and it will die, or become necrotic, as they call it. So when you have a large tumor, the drugs can't get in there and get rid of it. When you have a small group of cells in a very precancerous stage, just about anything you give that group of cells is going to kill it.
So it's much easier to treat.
Incredibly.
And again, it hasn't metastasized yet, which is another negative phase of cancer.
So drugs that won't work on a tumor that's much bigger will work very well on a precancerous.
So you need less treatment. And again, with targeted therapies, because it's going after just those mutations,
you could clean it up before it ever happens.
Absolutely. And again, side effects are so much different with targeted therapies versus chemotherapy.
Yes.
Yeah. Well, thank you, Alex, for taking this
Thank
time
you,
out
Michelle.
to talk to us. Thank you very much for your questions, everybody. I hope you feel you benefited from the time we spent together today. We will be doing another Facebook Live very soon, so please make sure that you click the follow button on your screen and make sure that you get notified when there's another one coming up. It'll be in the next week or two. If you missed this one live and you have some questions you'd like us to answer, you can send them to us through our website. You can get a hold of Alex directly at contact@ctome.com. And I think that's about it for me. Was there anything else you wanted to say?
Yes, feel free to send us your questions at any time. We just love answering questions and sharing information.
You can tell this
Anytime.
guy loves what he does. So thanks very much for joining us. Hope you have a nice evening. Bye.